I am very grateful to bring the triad framework to the medical profession because in my experience, when patients feel heard and understood by their doctors, they have a greater motivation to comply with their medical care. They have greater trust in their doctors, and the whole clinical encounter can become much more satisfying and productive, both for the patient and for the physician. I remember the story of an 8-month-old who had recurrent ear infections. And the mother kept bringing the little boy to the emergency room, and they would give him antibiotics, and the pediatrician was getting worried about the recurrent infections and the overuse of antibiotics. And when the boy was 12 months old, there was a finding of weight loss that was significant enough that the boy had gone from the 50th percentile to the 30th percentile in weight. And the pediatrician decided to ask the mother about the circumstances of their home and found out that the father of the boy had left her after many, many months of fights and marital conflict, and the mother had become very depressed, had stopped going out, had stopped eating herself, and found it difficult to cook. So the screening for the circumstances surrounding the little boy's symptoms led to an understanding of the difficulties that this mom was having taking care of this little boy, and the pediatrician was able to engage her in taking care of herself, seeking care for herself, and understanding the links between her own depression and the weight loss and the ear infections in this little boy whose whole body was responding to the stress of the conditions in the home. And by the time this little boy was 18 months old, the ear infections had disappeared and he was almost back to the 50th percentile again. So there is very real advantage in learning about the adversities and the link to the distress that patients bring to the medical office, and then enlisting the family strengths in order to interrupt the link between adversities and distress. In this case, the family strengths were the mother's extraordinary commitment to this little boy, and she was able to tell the boy's father about what had happened to the little boy, and the father started connecting with the mother around the care of the child, because he started realizing that 1-year-olds whose father leaves suddenly experience distress from the separation, and so this little boy was experiencing the confluence of the mother's depression and the father's loss in the context of the family conflict that had preceded the separation. So the mother and the father were able to come together around the care of the boy, even if they were not able to get back together as a couple. Triads is an approach that developed because we realize that what happens to people shapes who they are. It shapes how they feel about themselves. It shapes how they relate to other people, and it shapes their trajectory through life in terms of the choices that they make to take care of themselves. And so when we started our clinical practice, instead of asking people what their emotional difficulties were, we started by asking them what had happened to them as they were growing up. What were sources of pleasure? What were sources of pain? And as they told us about their experiences, we started connecting the dots between their growing up years and the reasons that they were seeking help from us. And as we asked them, do they see a connection between their relationship difficulties, their depression, their anxiety, their anger, and the memories that they were describing to us in their growing up years? We discovered that people responded with experiences of awe, relief, surprise, and particularly a relief of shame and guilt, because they realized that it wasn't their fault that they were not living up to their own expectations, that they were carrying pain that had been unrecognized even by themselves for so many years, and that being able to share that pain gave them a new sense of hope that they could manage it and they could create new realities for themselves. In developing triads, we try to distill the information that comes in a mental health setting where we have 50-minute hours where we can speak leisurely week after week about a patient's experience. We try to distill that information into a more streamlined, circumscribed approach where asking people to remember events from their childhood that were found to be predictive of later health problems, and to tell us what their presenting health difficulties are, and then help them think about what helps them and who helps them. Created gestalt, if you wish, where people could think of themselves more cohesively, and where the clinician could think, this medical condition might be the result of decades of stress as a result of severe maltreatment, for example, while growing up. And this substance use could be an effort to numb the pain that has been unrecognized and unvalidated for so many years. Triads is an effort to validate pain and to help patients understand the links between the assaults that they experience growing up and the health conditions that result from them. The three components of triads are asking sympathetically, supportively about adversities, asking also sympathetically and supportively about the patient's response to these adversities, the sources of distress that they have, and then reflecting together about their coping mechanisms, what helps them, who helps them, and what do they like about themselves that gives them a sense of pleasure and self-esteem. Adversities are difficult, painful life events that make people feel unprotected, fearful, and often overwhelmed, unable to cope. The term adversity was popularized by the ACEs study of adverse childhood experiences, where the researchers found that very frequent events such as physical, sexual, and emotional abuse, witnessing a mother being attacked by a family member, losing a parent to death, divorce, or other circumstance, growing up with a household member who has been imprisoned, growing up with a household member that uses alcohol or substances, and other similar circumstances, neglect, for example, are associated exponentially with the leading causes of early mortality and severe illness. Since the study of ACEs, we've also found that societal conditions like racism, poverty, lack of protective social shield, community violence are also associated with leading causes of mortality and morbidity. And so adversities are conditions that erode the capacity of the person to cope effectively with difficult life circumstances. Distress is a concept that tries to convey how stress that is not managed effectively, proactively, affects the body, the emotions, and how we operate in the world. So distress can have a variety of facets. It can come, for example, in the form of somatic manifestations like migraines, back pain, digestive problems, panic attacks. It can also be manifested in psychological conditions like depression and anxiety. And in the medical office, the clinician's role is to sort out the possible roots of presenting problems in adversities that the patient experienced both in their past and in their current circumstances that are creating the conditions for the health difficulties that the patient is experiencing. Strengths give the patient the tools that they need to cope with adversities without inner collapse. When a patient can resort to their optimism, to their faith, to their sense of a broader meaning, to their relationships, to institutions that give them a sense of life is worth living. Those are powerful, protective resources that counterbalance the impact of adversities and soften the distress that emerges in response to the adversities that we all experience. And the greater the number of strengths at the individual level, at the relational level, and at the societal level, the better protected an individual will be, the better equipped to deal with the impact of difficult life events. Physicians often express worry that asking patients about their experiences, both in terms of adversity and in terms of distress, is going to lead to excessively long and demanding clinical encounters. And when I talk to clinicians who have practiced the triads approach, they tell me that patients are very aware of the time constraints in the medical encounter. And what they really appreciate is the attitude of the doctor of wanting to know, wanting to understand, and feeling that together they can use that information to create a treatment plan that is tailored to the particular needs of the patient. And so the attitude is even more important than the amount of time that is devoted